Thank you so much, Tom. That was wonderful to hear all the things that you're doing as well. I know you're an expert at buffalo chicken wings and lots of many other things. Okay. Let me start out also by thanking Dean Smith and the School of Social Work for inviting me, and the Center for Social Work Research, Catherine Dulmus. And I'm finding out more and more about the world. I'm new to the world of social work and finding out more and more about it every day. And I must say that this group has been very, very welcoming and very instrumental in my just my comfort. I sort of hung out with them at the most recent conference and went to their party and ate buffalo wings, and they sent me home with some sauce from Buffalo, and it was great. As I've come to know Catherine, I'm learning that she's one of those rare individuals that blends passion and caring and hard work and just a wonderful associate dean for research and director for the center here at UB. She just sort of makes you want to become part of her world and part of her vision. So thank you. No. She's wonderful. So, and just also while I'm here, I just wanted to acknowledge and kind of give a special thanks to my dear friend and colleague Gerard Connors, who encouraged me to come to Buffalo and visit for many years. He has been very open about an invitation to the Research Institute on Addictions. Gerard is just an amazing person. I'm sure many of you know him, but he's been a gentle guide and mentor to me for many years. So it's fun to be here on your home turf, and thank you for that. So I'm going to tell you a little bit sort of about myself, my journey, and how I got into the work that I'm doing. Describe some of the studies. We're doing a number of studies using the Transtheoretical Model, and then go into some detail about a couple of those studies and certainly answer any questions that you have. So just so you know a little bit about what's important in my life, here is my family, and you've been able to take a look at them. Jerry, my husband of, I hate to say this, but almost 35 years this year. So long time. We got married at 10. And Jerry likes to run. He's a runner and does long-distance biking. And my son Keith and his wife, new wife Heather. Heather's a dear, and she is just, she's a counselor, psychotherapist, and she's learning how to do motivational interviewing training. So we did a training together on Friday, and that was fun. That was wonderful. My youngest son Daniel, who's a musician. There's always an artsy one in the family that you worry about. Me kid. That's my baby Daniel, and it's our cat Spork. He packed his bags and wanted to come with me, but I told him he had to stay at home. So, okay. Just last year we hiked the Grand Canyon from the North Rim to the South Rim. Gerard, you remember we talked about this, and it was, for those of you who have never done it, I don't recommend it. But as I thought about this talk, I realized that there are a lot of parallels with doing research and with being part of a research center and director of a research center. So, you train hard. We got up very early. We needed to be persistent as we were hiking through the canyon. There were times that I was miserable and I thought I was going to die. Just like those times that you get a manuscript rejected, or you put your heart and soul and all your work into writing a grant proposal and it comes back unfunded or unscored. But at the end, there's some things along the way, nonetheless, some beautiful sights. We get reinforced every time we do get something accepted, every time we write a research grant and it does get funded. And it's when you get into this research world, it is a wonderful world to be in much of the time. Rewards are magnificent, very reinforcing, and it kind of helps us keep going at those difficult times. Okay, so let me back up and just tell you why. The reason I'm going to tell you about how I got to be here is because it all kind of fits together with the research that we've been doing. Some of you will recognize this guy in this picture. This is Carlo Di Clementi, And I don't know what this means in Italian, but I can guess. Gerard, you probably know. Anyone who knows Carlo can probably tell you. This is the day Carlo turned 50, and we all dressed in black to mourn the passing of his youth. So that's what the emotion is about there. So kind of go back and tell you a little bit about how all this fit together for me. I got married very young, as I mentioned. I was a smoker. I had 2 little boys at home. I was talking to someone earlier who's got 2 little, where'd you go? Who's got 2 little ones at home and is trying to, there you go, yeah, trying to fit together the life of having 2 little boys, a year and a half apart, figure out how to work, how to do my career and all of that. So I was in a very, very similar place. I invited my mom to come over one day. I had a sore throat, and so she was kind of helping out with the kids. I was very bored and didn't know what I was going to do with my life and my career. I knew I wanted to kind of spend some time at home with the kids, but really also then at that point, they were 3 and 5 or something, and wanted to know what I would do career-wise. So I picked up this little throwaway newspaper, and there was an ad that said, if you're a smoker and you don't want to quit, call this number. And I was completely, I don't know why I did that, just bored and didn't want to quit smoking. Called the number and ended up enrolling in this research study. And the research study was about smoking, and all they did was they sent these questionnaires. But they sent the questionnaires like every 8 weeks. All I had to do was send them back. It was a whole big, thick stack, and I got paid $8 every time. So I thought that was kind of fun. And as I filled out the questionnaires, I learned more and more about my smoking, even though there was no intervention. Ultimately, I moved to California. Those researchers tracked me all the way to California. They tracked me. We moved back to Texas. I couldn't get them out of my life, and my there. And my husband kept saying, why are you doing this? And I really didn't know. It's kind of one of those things that I don't know why I'm doing it. I said, they give me $8. And he said, well, I'll give you $8 to not fill out these questionnaires. But nonetheless, I stayed involved. And a few years later, I wanted to go back and finish my degree. I hadn't finished my degree. And then I wanted to go to graduate school. I didn't know anybody. I thought, I took accounting for a couple of years. And I thought, well, I might want to do something else. And I liked psychology. And I didn't know anybody in the world of psychology. So I wrote this guy a letter that had been head of this study and said, can you tell me something about psychology? And I thought his secretary would maybe, write me back. So one day I'm home with my kids, and the phone rings, and it's Carlo Di Clementi on the phone. And Carlo said, yeah, you wrote to me, and let me talk with you about psychology or social work or, what you might want to do. And I was like, get a pen and all nervous. And so anyway, fast forward a few years. It was very nice. Fast forward a few years, I needed a letter of recommendation for graduate school, as many of you can understand. And one of my professors said, undergrad professors said, well, you mentioned that research study that you were in. Why don't you call that guy, see if you can volunteer in his lab. My best friend works in his lab, or his girlfriend works in the lab. And so I called and said, would you like a volunteer? And she said, believe it or not, no, we don't need volunteers. We're all filled out. Thanks anyway. And an hour later, she called back and said, Dr. Di Clementi wants to know if you were ever in one of his research studies. I was like, yeah, I talked to him on the phone. So anyway, I went in and started volunteering, and then I just got hooked. So I started out as a volunteer in the lab. I then went into being a research assistant, went on, finished my master's degree in clinical psychology, became a project director for, Gerard will recognize Project Match, and continued working in that lab for many years. So as the Transtheoretical Model was kind of coming along, I was very involved in that research, met Joe Caminari, who's a wonderful statistician, and then ultimately Carlo decided to leave, and he went to the University of Maryland, Baltimore County. So I hung in there and worked with Joe and another man, Kirk von Sternberg, who's up there way on the left. Look, he's these are old pictures. You can obviously see me with a funny haircut. Anyway, so stayed there and became involved. We said, if we're going to stay in this grant biz, we're going to have to really write some of our own grants. And in those days, we wrote 3 proposals, hoping that one would hit, and they all hit. So we kept sort of the enterprise going. And so let me just tell you a little bit about the Transtheoretical Model for those of you who are not familiar with the model. This has become kind of the my area of interest and certainly the base of all the research that we've done through the years. How many of you are familiar with the Transtheoretical Model? Gerard, you wrote a book on it. Okay. How about the stages of change? Okay, yeah. So the Transtheoretical Model, just very briefly for those of you who may not know this piece of it, is that years ago, 20, 25 years ago, Jim Prochaska, who's a psychologist at the University of Rhode Island, and Carlo Di Clemente and some others were studying the whole process of change. What is it that happens when a person makes a behavior change? If you're going to change one person's going to change their smoking, and another person's going to start an exercise routine, and another person's going to change their diet. Do we do it in a way that's similar, or do we do it in ways that are different because we're all individuals? If I go for help to a psychologist or to a social worker or to a physician, do I change in a way that is different than if I change on my own, sort of self-help? Or if I'm in group as opposed to individual, how does that look? Well, what they did was they studied many, many, many people and the whole notion of behavior change, and they learned that change tends to happen in a very predictable way. So they looked at lots of systems of psychotherapy, lots of approaches to treatment, and realized that, and talked to lots and lots of people, mainly smokers at the time, and learned that this behavior change seems to happen in a way that as people are thinking about changing, when they're early in this process, they think certain things. Their consciousness is maybe raised. They become aware that there's a problem. They begin to evaluate their life. They do what we call self-reevaluation. Think about what would life be like if I didn't have this behavior. Maybe something dramatic happens, a car accident, or someone in the family gets cancer. I remember once I did a talk and a woman came up to me at the end and said that she was a strong smoker, couldn't quit until her cat got lung cancer as a result of her smoking. And for her, that was the one thing that was kind of the dramatic relief, the event that made her decide that she was going to quit. Okay? So these experiential processes seem to happen early on. Consciousness raising, self-reevaluation, dramatic relief, environmental reevaluation, and social liberation. Okay? Environmental reevaluation is when there are things that are happening kind of in our own environment. And then behavioral processes. So as we're changing, we begin to do certain things. As we move through what they later termed the stages of change, some self-liberation. We make a commitment to change. We decide what it's really going to be like, and we take some steps forward. Counter-conditioning. Maybe we change, we replace one behavior, an unhealthy behavior, with a healthier one. Maybe I replace my smoking with, chewing cinnamon sticks, or I go out for a run instead. Stimulus control, just controlling the environment, staying away from the bars, taking the beer out of the fridge, hiding the chocolates. So making changes on our environment. Reinforcement management is rewarding ourselves and then helping relationships, getting help along the way. So those processes of change, help from other people, developing relationships, finding a friend with whom to go to the gym and exercise, and those kinds of things. So basically those processes of change were the main part of the model that I was very interested in, and that's the part of the Transtheoretical Model that developed first. What's happening as people change? What became much more much better known was then that they learned that these things didn't happen in a random fashion. They happened in a very predictable way. And that's what they termed the stages of change. Okay? So these experiential and behavioral processes happened in a very predictable fashion, and people moved from not thinking about changing, which is pre-contemplation, as you know, through contemplation, preparation, action, maintenance, and hopefully on determination. So these processes, I became very interested in trying to figure out, can we facilitate this process of change in people? How can we do that? What do you do with pre-contemplators? When people aren't really thinking about changing, how do you help move them toward thinking about change? Okay. And some other constructs of the trans-theoretical model that have been studied are decisional balance. I mean, these are constructs that are not just related to the trans-theoretical model, but constructs that fit very well within this framework and self-efficacy. Okay. So at the University of Houston, stayed there for several years, and then a friend asked me if I would be interested in moving to a medical school. Said absolutely not. I'm happy here in the psychology department. Wouldn't want to do anything else. Don't want to work with physicians because they probably, I probably wouldn't fit in a world of physicians. And she said, just come and talk to these people. I went and talked to them and fell in love with the world of family medicine, family and community medicine. They were terrific, terrific people. So Kirk von Sternberg, who was on our research team, and I moved over to University of Texas, the medical school in Houston in the Department of Family and Community Medicine. So I was there for 7 years. And so our research really then began to shift from looking like some of the things that we'd done with sort of full-blown therapy to briefer interventions that could be done in medical settings. So I became very interested in that. Many of you will recognize this. Catherine, this looks very much, you showed me a room yesterday where you assemble your grants. This is our research team at the medical school. We grew and we had several more grants get funded, and I became director of research at the medical school in the family and community medicine department. So you'll recognize on the board it says original +8. So when you're assembling NIH grants, what you need. And this is our group. We had lots of fun. Some of you will recognize Joe Carbonari, who is he was one of the Project Match investigators. So I'm having a great time, loving the medical school, loving that whole life, and I got a call asking me if I would be interested in moving to Austin and consider working in the School of Social Work. And I listened and didn't think it was related to me. I thought it was Diana DeNito, and I thought she wanted a letter of recommendation. And at the end of the call, she said, would you apply for this position? And I said, I will move from Houston when hell freezes over. I love Houston. I'm not moving away. Would never consider it. And then, and it didn't come in the form of hell freezing over exactly, but it did come in the form of, you remember the Hurricane Katrina and Rita. So I got a call from David Springer, who was the Associate Dean for Research. He is the Associate Dean for Academic Affairs, and David said, I know Diana told you about this position. I know you're probably not interested, but if you ever come to Austin, just meet with Barbara White, who's the dean, and I and Diana. We'd just love to talk to you. We'll take you to lunch. It doesn't matter. If you come in the middle of the night, we'd just love to talk with you. And I said, okay, if I ever get to Austin. Meanwhile, my kids had gone on to school and were living in Austin. And I said, I don't think I'm planning to be there anytime soon. Well, the very next day, Katrina was over, but this Hurricane Rita was threatening the Gulf Coast, and they closed the medical school and basically evacuated the part of the city we were living in. So I called David and said, I'm on my way to Austin. And he said, I don't care when you get here, let's have lunch. So I went and had lunch with Barbara and David and Diana and said, this wouldn't be such a bad place. In fact, maybe. And my kids were saying, you got to move to Austin. We're going to have kids someday, and you might be a grandma, and anyway. So I've only been there for 8 months. Okay. So our research, and this is kind of our group. We're reestablishing. Some of you recognize that guy. Again, many people have been incredibly supportive. Gerard and Carlo and Joe Carbonari and some folks just recently came up for an investigators meeting. So this is where we are in our research. Okay, so that's just kind of the journey. It didn't happen, in any kind of way that I planned or anything that I, decided I was going to set out to become an associate dean in the School of Social Work. But it happened very, just in ways that have made it a really exciting kind of process for me. Okay, so the Transtheoretical Model offers a very integrative framework, I think, for understanding, intervening, and measuring behavior problems. So the model, if we think about the whole notion of how do you put together an intervention? What is it that helps people to change? The Transtheoretical Model, I think they did a very good job of adopting measures, adapting measures, developing measures to look at this whole process of change. How do you measure it? How do you measure the stages of change? You know, are the stages discrete? And some of you will be familiar with some of the questions right now in the literature. Are they more continuous? Do you measure it using an algorithm? Is it different, just kind of the stage, measuring stage, is it different for smokers than it might be for you know, something like readiness to engage in treatment? What about for people who are duly diagnosed or have comorbid you know, mental illness? How does that all fit together? So the measures were there. I think the measures were really are really, you know, kind of nicely in place. But rather than just measuring change, then how can you promote it? How can you foster change? And again, I still wanted to know, what the heck do you do with people in pre-contemplation and contemplation to help them move along? Well, right around that same time, at the beginning of Project Match, is when I became familiar with motivational interviewing. Right? And how many of you know about motivational interviewing? Most of you here. Okay. Well, motivational interviewing, I thought, was a very nice way to look at, you know, this whole early stage movement, and maybe to facilitate change kind of early on. And so we got very involved in when we wrote our grants, we decided to use motivational interviewing as a component of that and really see if we could use it to foster the change processes, these experiential and behavioral change processes. So using the Transtheoretical model, you assess the client's readiness to change and enhance their motivation through a series of strategies depending on how ready the person is. Okay. So many of you know about motivational interviewing. It's a very empathic yet client-centered counseling style. And according to Bill Miller and Steve Rolnick, who were the originators or who developed motivational interviewing, it's the whole notion of resolving ambivalence and acknowledging ambivalence and encouraging ambivalence and trying to figure out, you know, how, you know, when there's a tension between my behavior and my goals for my life or my values, you know, that's probably a good thing. And with our clients, rather than confronting them and, you know, or educating them or shaking our fingers at them, what we want to do is help them recognize their own ambivalence. There's nothing wrong with education. People here will you know, agree that lots of people change once they learn about things. But education alone, as you know, is not enough. The whole confrontational approach to helping people change works for some people, but not for everybody. And but this whole notion of ambivalence and helping the person discover their own tension, if you will, between their values and their, you know, their current behavior, or between their goals for their life, is pretty intriguing to me. So why motivational interviewing? Why did we start incorporating that into our studies? Those of you who have studied motivational interviewing, and I know a lot of you are using it in your work, and many of you who are teaching it, I've already been cutting deals with people about, if you share your syllabus, I'll share this little videotape that I have. So why motivational interviewing? There are more than 130 clinical trials right now. It's a very well-researched approach to treatment. So it's very evidence-based. And we know, you know, there are very few things that have really been studied that closely. We use a lot of approaches, especially in our community treatment programs, that are not quite as evidence-based. There are some exceptions. CBT, there's some very, very good ones. But motivational interviewing, I think that they've done, I give Bill Miller a lot of credit for this. Bill did a really nice job, I think, of asking the questions, encouraging the research, and being open to a lot of the questions that were being asked. It's relatively brief. It can be brief. You can do motivational interviewing. I think you can do it well in briefer sessions if you use some of the strategies. It's specifiable. You know, we can define it. We sort of know what it's supposed to look like. It's grounded in theory. We know the mechanisms of action, and I'll talk about that. We think we know. People, you know, what the mechanisms of action are in motivational interviewing. People have been very good at taking that black box. What's happening inside that counseling session, and how can I how can I look at that? People are audio taping or videotaping sessions. There's coding mechanisms, ways to score motivational interviewing, ways to look at if the therapist or counselor is, or physician or whomever is using it, if they're keeping, if the integrity is there. So there's really been some good research around that. Generalizable across problem areas. It's being applied to, again, diet, exercise, lots and lots of different behaviors, lots of health behaviors, in addition to working with more traditional therapeutic, in more traditional therapeutic situations, complementary to other treatment models. So it's not like, well, you're going to learn this new approach, but you have to throw out everything you've done before. You can use it very nicely, I think, with a number of other models. And we know if it's being delivered properly. There's something called the Motivational Interviewing Treatment Integrity Coding System. Okay, so many of you know this, but I'm just going to go over it, for I know this is a very broad audience, and with a lot of different backgrounds. So there are a few assumptions underlying motivational interviewing. And the first is that motivation is a state of readiness to change. So it can fluctuate from one situation to another, and the state can be influenced. So when I'm teaching this, through the medical school, I ended up doing a lot of teaching of residents and faculty, physicians. And one of the things I do when I work with them is I say, we're going to do this little exercise. Medical students, those of you who have ever taught in a medical school, you go in and medical students look at you, their eyes glaze over, and unless you're going to teach them how to, prescribe, they're not much interested if you say the word behavioral near your name. They're not much interested. Once they get to be residents, they're more interested, in my experience, once they get to be fellows, and then actually physicians who are working with people, they come back and go, this stuff is great, you got to teach us about this stuff. But the med students are kind of, what's this behavioral stuff? So one of the things I do with them, just kind of as an example, and I'll do it with you if you kind of bear with me for a second. I won't get you to get up and move around the room, but I put little signs around the room. Over here in this corner it says not ready to change. Over here in this corner it would say thinking about changing. Over here it would say preparing to change, and over here it would say no more TV for me. And then I tell them that Dr. How do you say your name? Wyzorek? I always pick the hardest name. Dr. Wyzorek. And it's usually a medical student, who's not a doctor yet. And I say, Dr. Wyzorek has just completed a study, right, Dr. Wyzorek? Good study. And what he's learned is that watching TV causes brain damage. Okay? And now that we know, good, and I ask them what journal they published it in, and they're always creative about that. Watching TV causes brain damage. And well-respected journal, great study. The results are just now out, and you need to decide for yourself. I'd like for you to decide where you are with regard to your TV watching. Okay? Important study, great researcher. Now I'd like for you to get up, but don't do it, but I would like for you to get up and stand in the corner of the room that best represents where you are with regard to your TV watching. And then they all go to the four corners of the room, and there's usually a pretty good distribution. There's a whole bunch of them over in the not thinking about changing, and a pretty good group in the thinking about it, a few in the preparation stage over there, and then one or two say no more TV for me, that's it. And so then I start asking them, tell me why you're over here. And, and you get things like, well, I don't watch it that much, and, it really helps relax me, and all the things that your clients would say if you were, working with clients. And then I ask people in this corner over here, this contemplation stage corner. Then, of course, we talk about the stages of change and, why are you there? Well, I need more studies, or I've got to weigh the risks against the benefits. Very, very much like we know people in contemplation are weighing the pros and the cons, and they're about balanced in contemplation. And then as they move into preparation, that balance begins to tip. So, but anyway, it's a nice way if you, and you can steal that because I stole it from someone else, Jeff Parsons, who's in New York. But it's a great way to kind of get people thinking about this whole notion of motivation being a state of readiness to change, and it fluctuates from one time or situation. And then I'll ask them, now where would you put yourself if I asked you about eating chocolate? And what corner of the room would you be if I asked you about your exercising? And they, wow, I'd be way over there for that. So the whole thing is, and then you can kind of talk about motivation being a state of readiness to change. And it's just very different. And the med students aren't saying, oh, that person's not motivated. They don't, forget it. They're just wasting my time. And then we talk about the fact that motivation does not reside solely within the client. It's an interaction. And I'll say to people, again, a lot of us who do motivational interviewing training use the analogy of a teacher. Think back to your elementary school, and did you have a favorite teacher? And a teacher with whom you felt particularly motivated, and what was that teacher's name? And tell me about that teacher. And almost invariably, they'll tell you the teacher, well, that person, they cared about me. Maybe I wasn't the best student in all my classes, but that teacher found ways to make it interesting. That teacher found ways to tailor the experience to me. That person cared about me. Very much consistent with the philosophy or the assumptions around motivational interviewing, that the motivation for change is not about the client necessarily so much as it is about the interaction between the therapist and the client. And that the counselor's style is a powerful determinant of resistance and change, and an empathic style is much more likely to bring about what we call these change statements and less resistance from the client. Okay. People struggling with behavioral problems often have conflicting motivation. It's that ambivalence that we talked about that's very normal and not pathological, and that each person has a potential for change. And, our task as counselors is to release that potential. And I won't spend a lot of time on this because many of you know about motivational interviewing, but underlying the whole spirit is collaboration. The counselor's not the authority. They're there to create a positive atmosphere that's conducive to change, evoking ideas about change from the client, not imparting our wisdom, but eliciting the client's views on change, and leaving the responsibility for change up to the client. It's not my responsibility to make you change. All the stuff that you would say when you start a session, I couldn't change you even if I wanted to. I'm not going to try to force you to change. And when it's done properly, it's the client that's presenting the argument for change. Okay. So in motivational interviewing, there are basic interaction strategies, just to kind of refresh everyone: asking open-ended questions, affirming the client, reflecting back to the client. In a motivational interviewing, the reflections are a big part of it. So it's reflecting at different levels, learning when to reflect and when not to reflect, and at with what sort of level of complexity, and then summarizing. The whole idea behind it is to elicit change talk, having the client present the reasons for change, and the therapist or the clinician facilitating that, not trying to manipulate or sculpt the client's will. And here's Bill Miller's kind of idea about how this change talk happens. And in motivational interviewing, once you start hearing change talk, the client is telling you reasons for change. And those people who do motivational interviewing, what do you do with it when you hear change talk? Reflect it. Exactly. Reinforce it. You reflect it. And the beauty of motivational interviewing, as many of you know, is that it's very it's client-centered, very consistent with social work and social work values, but it's also it's also directive. So we have a goal in mind. So the flow of change talk is, the motivational interviewing elicits from clients this desire, ability, reasons, statements about desire to change, ability to change. I can do it if I want to, if I really set my mind to it. Reasons they should change, and the need for change. It seems to be what's happening is that then there's some commitment language about change, and that's when change happens. Okay? So this whole notion of change talk really enters into a lot of our research. So let me tell you just very briefly about some of our studies that we've had over the past 6 or 7 years. And then I'm going to tell you in particular about 2 of them. Project Choices, I'll describe 2 in more detail. But this was a large study that was funded by the CDC. It was a multi-site, relatively large, a multi-site study. So there were 3 settings across the country. CDC came, put out a call for proposals and said, we're looking for women who are at risk for alcohol-exposed pregnancies, women who might be in settings where they would be at higher risk, and how can you help us find those settings? Because the ultimate goal is to prevent fetal alcohol spectrum disorder, or FASD. So we decided to respond to this call, and we thought, well, where can we find women in those circumstances? Well, one of the things we decided was that Harris County Jail, which is the 4th largest jail in the country, Harris County Jail would be a great place. And then treatment centers. Okay, women who are in treatment for drug and alcohol problems would be probably very likely to be at high risk. other people across the country responded and were funded. So they funded 3 sites, and each site had to have 2 settings. So ours were the jail and the treatment centers. Mark and Linda Sabel, who were in Florida, decided to do a media-recruited sample. They're Broward County, just put an ad in the paper. Those of you who know Mark and Linda know that that's a lot of what they do, is they do media recruitment and some guided self-change. So they were funded for that, and then I think it was an OB-GYN clinic, and then 2 other settings at in Virginia. It used to be VCU. Now it's something else, but Virginia Commonwealth. What is it now? Anyway, they recently changed. So in that study, and I'll tell you more about that, we used 4 sessions of motivational interviewing while the women were in jail, 2 sessions and 2 sessions after they got out. Another study funded by NIAAA, where we did something very similar, preventing pregnancy after a jail term, where we had 4 sessions, but then we had a social worker come in and work with the people during that time. STI screening in young women. Women in Houston, there's the Acres Homes area. I don't know if any of you are familiar with Houston, but they have the highest rates of chlamydia and gonorrhea in the country, among the highest rates. So we thought, well, could we train health educators to do this? You know, if you know, we kind of think we know with counselors how, you know, to go in and use this approach, but could we train health educators to work with girls who are at risk? And it wasn't about condom use, but in this case it was about screening. So we wanted them to know when they were at high risk. So if they had sex with someone and didn't use a condom, if they found out their partner had an STD specific to chlamydia and gonorrhea, you know, could we get them to go in and get screened? HIV risk reduction in alcohol abusing men having sex with men. It's a NIDA study. This is with Jeff Parsons in New York. Transtheoretical model group therapy for cocaine, and I'll tell you a little bit more about that in a minute. And then we got very interested in screening and brief intervention in primary care. Can we use motivational interviewing in a doctor's office? Can we use it in emergency rooms? Can we teach resident physicians to do this? So Paul Seal, who is a physician in Georgia, and I wrote a grant to train resident physicians, and NIAAA funded it. It's an R25. So we're doing that. And then we got involved in this big SBIRT project. Anyone know about SBIRT? Have you heard about that? No? It's a big project funded by SAMHSA and Centers for CSAT, Centers for Substance Abuse Treatment. And they decided that this whole screening and intervention thing in medical settings is probably a good idea. And what they so often do, I think, is they jump ahead of the research. But they said, now that we think this works and people are kind of studying this motivational interviewing thing, you know, we'll just put it everywhere. And so they funded 5 centers across the United States, $17.5 million each, to go in and do screening and brief intervention in emergency rooms and all sorts of different places. So in Houston, they asked us to get involved after it floundered for a couple of years. They couldn't quite figure out what they were doing. And we went in and we do all the training and supervision for that. We do workshops, and then we do follow-up coaching. So I have a team of coaches who go into the community, observe the sessions. The sessions are audio taped. They get very good supervision, and the last year they studied it in Houston, and they had the Harris County Hospital District, and it looks like they had about a $4 million reduction in return visits to like the emergency room. People were using primary care much more, in much better ways. So there's a lot of some pretty good payoff for that there. So that's the SBIRT project, and you'll probably be hearing a lot more about that, I think. It seems to be making quite a splash now, especially the White House likes it and all sorts of stuff. Robert Wood Johnson study where we worked with pregnant women, smokers, and did ultrasounds. This is with Jan Groff, who is a physician at our place, or my former place. And then we were just recently funded with Karen Ingersoll. So this Project Choices study that I'll tell you about, they funded the study. CDC funded it for 9 years, and I'll tell you about that. it turned out to be pretty effective, but NIAAA gave our group way more money to study why it was effective than we got to actually do the 9 years of the study. So they just funded a Mechanisms of Action award, so we can take all the therapy tapes that we have from that study and look at kind of what was happening. We can code the tapes and we can look at those interactions and figure out. So it was Mark and Linda Sabel, Karen Ingersoll, and I, and a guy named Chris Wagner just got funded to do that. So there's been lots of exciting stuff in my world around the motivational interviewing and around the transtheoretical model pieces. Okay. All right. So I kind of told you about those different studies already, and I'll tell you more again about 2 of them. Okay, so then if you think about using these brief interventions in medical settings, as we moved into the medical school, we wanted to use them in medical settings. We wanted to train the physicians to have some specific skills to use, but we didn't want them we wouldn't want them to do this. Not to be too general. We wanted to use it in general practice, though. Okay. So related then to the healthcare setting, I mentioned this Robert Wood Johnson study where we worked with women. These women were heavy smokers, and we had them come in, and we taught the ultrasonographer, the person that was doing the ultrasound for the woman, how to use motivational interviewing to work with the woman. So it was like the woman came in. One condition got best practice with a nurse, very good nurse, in a GCRC, which is our research unit. Another got best practice plus a session of motivational interviewing, and the third got best practice with a nurse and then just some advice. So the woman came in, the sonographer said, do you want to see your baby? A lot of them, again, they're high risk because they're smokers. Do you want to see the baby, and do you want to know the gender, and here's her little arm, and here's her little heart, and here's the umbilical cord, and by the way, do you know what happens when you smoke? And but in a way that was hopefully motivational, but not too threatening for the woman. I'll fast forward a little bit and tell you the results of that study are, as so often happens, we don't have big main effects among the 3 conditions, except for the fact that the people who are smoking less than 10 cigarettes a day seem to do far better in the motivational interviewing condition. Otherwise, all conditions seem to do well, and people did actually very well in the best practice condition. Those darn nurses did a very good job of giving advice, and the women changed, but I hate that. Happens. Okay. So I kind of got ahead of myself. I told you already about the ESPERT project and the goal, and then the residency training project that we have. So one of them is funded by NIAAA, and one of them is funded by SAMHSA. Okay. One other kind of interesting thing I just wanted to mention to you is this is not a study, wasn't a funded study, but we were paid to do a little bit of training in South Africa. And I went there, been there a couple of times, working with medical workers, so nurses and physicians, and trying to work with them around the whole notion of using brief intervention with patients who had HIV or other STIs. In Cape Town and Port Elizabeth, the way of working with people was very punitive, and the women would, the nurses would yell at them, and we had 2 people come up, and this is part of a videotape that we made. I won't show you the tape, but they would say, why aren't you using condoms? And, you have no excuse. And, and they would say, well, my husband refuses to wear a condom. I don't care. You use it anyway. And they're over there in that cabinet, and you go get it, and you put it on, you take it with you. So it was a very interesting project, and it felt really good to work with these folks in South Africa. Here they are after a couple days of training, and I wish it could have been a research study so we could figure out how they're doing now, but it was a really good experience. Okay, and then again in the medical setting, we taught medical students how, we asked doctors out in the community, how can our medical students help you when they go out on their preceptorship programs in the summer? What can they do? Usually they hang out, they shadow the physician in the office, and they would come back and say, yeah, it was a good experience, I learned a lot, and the docs would say, it's fine having them there. Well, we asked the docs, how can these medical students really, make an impact on your practice? And they said, talk to the smokers. Have them do, I don't have time, smokers don't want to talk to me, but teach the med students to do that. So what we did was we taught med students to use motivational interviewing, and I'll show you in a minute kind of the scales that we had them use. Very basic MI stuff. We didn't teach them full-blown motivational interviewing. Couldn't have done that if we wanted to. I had a short amount of time with them. They were in the practice. People would come in and they would ask them about their smoking. If it was a smoker, they were asked to intervene with them and to sit and do some scaling, what we called scaling rulers with them. And it turned out to be a very, very good project. They screened smokers. They worked with smokers. We had the smokers send back these little postcards, and it seemed to be a good experience for the medical students. So this is published in Journal of Family Medicine. A lot of it was based on this book, wonderful little book by Steve Rolnick, Chris Butler, and Pip Mason on health behavior change. And it's really about using motivational interviewing in the medical healthcare setting. Very good book. Okay. How many of you are familiar with these scaling rulers? Okay. All right. Well, I'd like for you to think about, for me, humor me here for a minute, and think about your own behavior change and a behavior that you might be interested in changing. Something you'd like to change about yourself. Could be your diet, could be your exercise, could be your smoking. Try to make it nothing like cocaine use or something. Probably not the place to talk about it. What I'd like for you to do is I want you to think about where you are with that, your own behavior. Everybody have a behavior in mind? Raise your hand if you have a behavior. Okay, that you'd like to change. Okay. So I want you to think about where are you on this ruler. If you think about 0 being not at all important and 10 being extremely important, look at that ruler and think about where you would place yourself. Okay? Now I'm going to ask you to take a little bit of a risk, and I want you to just turn to the person next to you. Okay? Come on. Turn to the person next to you. Okay. Just very quickly. Very quickly. Okay. One person's going to be the speaker. Raise your hand if you're the speaker. Decide who's the speaker. Okay. Speakers, raise your hand. Okay. All right. Now who's going to be the listener? Should be the other person. Okay. 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 I'm going to ask you we're going to take about 5 minutes here, and I want the speaker, if you're willing to do so, nobody has to feel forced to do that. I'll just come and look at you funny if you don't. Just tell the person the one thing that you want to change about yourself, if you're willing to do that. Okay? And when your speaker tells you what they want to change about themselves, all I want you to do is ask them, where would you place yourself on that ruler? Okay? What number would you give yourself? And then begin to explore that. So if they say I'm at a 5, you're going to ask them, why are you at a 5 and not a 3? You always start with a higher number. Why are you at a 5 and not a 3? Or why are you at a 2 and not a 0? Why would you do that? Why would you start with a higher number on the ruler? Anybody know? And then go back. Exactly. That's what we're looking for in motivational interviewing. We're looking for change talk. That's exactly right. That's why she's the dean. is that that's what you're looking for. Okay. So your job is not to fix the person. Your job is only to listen. Okay. Listen to the person and use some of these questions. Why a 5 and not a 2? Okay. If they say a 1, what are you going to say? Why are you 1 and not a 0? Right? Very few people will say I'm at a 0, but if they are, you want to know that, right? And that's what I teach the clinicians that I work with. If the person says I'm at a 0 in terms of changing, what stage of change would they probably be in? Pre-contemplation. And wouldn't you want to know that as a clinician, that that's where they are? Okay. What would have to happen if it became much more important for it to become more important for you to change? What would have to happen before you seriously considered changing? So these kind of questions. Why have you given yourself such a high score? What stops you? And then I'll leave this one up. What are some of the good things about your use? What are some of the good things about your smoking? And those, again, of you who know motivational interviewing know. What are the good things? People wouldn't be doing it. These women wouldn't be smoking unless it helped them reduce their stress. It helped them. They worry that the baby's going to be too big. People have reasons for doing what they do. What concerns do you have about your weight? Right? And we don't ask, are you concerned about your weight? Why not? They could say yes or no. Exactly. It's a closed question. What concerns do you have about your drinking? What concerns do you have about your diet? Okay? Elicits from the client any concerns they have. If you were to change, what would it be like? And then we always end with kind of, where does this leave you now? Okay? So let me just ask you, turn to the person next to you and ask the person where they would place themselves on that scale, and then ask them a couple of those scaling questions. Again, it's not your job to change the person, just to listen and understand. Okay, go. Let me take just a minute to I'm going to ask you just quickly how that went for you. Anybody get free therapy? That's what we're about in the world of social work. We're going to help you out here. Okay, and then the next thing you would want to do a lot of times is then clearly you would ask the person, how confident are you? Okay, on a scale of 0 to 10, with 0 being not at all confident, 10 being extremely confident, how confident are you? I'm about a 5. Tell me why you're a 5 and not a 4. Elicits any ways that they've changed in the past, any other experiences they've had with change. So you would ask some very similar questions, and this is what we're shooting for. 3 and confident. Okay. Any just quickly thoughts about that, the ruler? Yes.
I think with me, I was a talker, and the way the questions were asked, it didn't leave me defensive.
It didn't leave you defensive, so you felt like no one was really forcing you.
Right.
Yeah, that's what I like about the scaling rulers. To me, a lot of times, if you only have 15 minutes with somebody and you ask the scaling questions, it's a nice way to kind of elicit it with those change statements without having the person feel like they've got to defend their position. Yeah. Okay. Yeah. Yeah, exactly. So some things that I'm not quite ready to think about. Okay. Right. Okay. Thank you for doing that. I think there's no substitute for actually giving it a try. And with motivational interviewing, for those of you who do motivational interviewing, or if you're learning how to do it, these little rulers, the decisional balance exercises, these are strategies that you can use all your MI skills with. You can use your reflections, you can use your open questions, but they're really, I think, nice ways to integrate a lot of the skills. Yeah.
Carrie, I'm working with clients who are cutting a lot themselves a lot,
Mm-hmm.
and when I get somebody who's especially really tied to that behavior, really not interested in changing, I've actually started with what are the good things about the behavior, and I wonder, would that be not okay from this model? Because it's more like that puts them sort of like, oh wow, I mean, she was going to ask. They're really waiting for me to move into a convincing mode and
Right.
Join with them a little bit more. But I'm now wondering if that's not an okay thing to do.
No, that's a perfect thing to do. Thanks, Nancy. That's a really good question. And as you see here, I'll go back to this slide. I almost always start out with what are some of the good things about your behavior, because it seems to kind of take that judgment away. And I usually say, if you wouldn't be doing it if you weren't getting some benefit out of it. And it's sort of, then you can begin to develop that rapport. Well, no one's ever asked me about the good things about it. Why would somebody cut themselves? But just kind of understanding where they're coming from, and then say, what are the less good things? I don't say what are the bad things, but what are the good things and then the less good things. I think it's a really good way to establish trust, and then summarizing those. So on the one hand, it sounds like there's some really important reasons for you, and I try to say what they are that they told me, and then on the other hand, there's some not good things, and then just always be careful, because we can be so tempted to use the not good things as a laundry list against them, because now they've told us the reasons they shouldn't do it. So I love that idea of starting with the good things. Okay, quickly, some other projects is we've worked with dental schools, again in South Africa. I love to work there, just teaching dentists, working with dentists around promoting healthy behaviors. I mean, who better than a dentist? They can talk, right? Person got a captive audience. Yeah. So we've taught some dental students some skills. Okay, so let me just quickly tell you about this one study, so you can kind of get an idea of how we use motivational interviewing in many of our studies across the board. So as you know, fetal alcohol spectrum disorder is one of the biggest causes of mental retardation. It's entirely preventable. If a woman does not drink during pregnancy, the baby will not have FASD. And fetal alcohol spectrum disorder is the newer term that used to be, they would talk about FAS. But it turns out that there are a lot of effects, everything from potentially from a woman having 1 or 2 drinks a day, that where the child has some attentional deficit disorders or some behavioral problems, all the way through the full-blown facial dysmorphology and fetal alcohol spectrum disorder. And actually just testified in Texas before the legislature last week about mandating, trauma centers are now mandated. All the level 1 trauma centers, the American College of Trauma Surgeons has mandated that level 1 trauma centers all have to do screening for drug and alcohol use, which I think is a really good thing. And all level 1 has to do screening and brief intervention, and level 2 just has to screen. So I've been working with the CDC, the American College of Trauma Surgeons, to try to get some of this integrated in, and I serve on their task force, and then I'm on the governor's task force for fetal alcohol spectrum disorder prevention in Texas. And so they just had this hearing where they're trying to mandate screening for all women of childbearing age when a woman goes in for a doctor's visit. Well, there's all sorts. I think that could be a really good thing, but there's all sorts of issues around confidentiality and where does this end up in her medical record and who's going to get the information and all of that. So it's been a very, very kind of a hot topic, and I don't know whether that bill has passed. And with I said, well, I'll go and talk to them, but we have to talk about these kind of amendments and where things would end up. And so the screening and intervention I think is a really good thing, but I also think we really have to worry about what information we're asking people to provide and where does it end up. You probably, those of you who work in the community, probably know far more about that than I do. So Project Choices, anyway, was this study that I told you about, this CDC-funded study. And this is an example of the CDC, I think, doing a very good job of funding us all the way through, from the beginning of thinking about the problem through to a clinical trial. I must tell you also that about 3 weeks ago we were in a meeting, all the players here, and we got a call from the CDC. This is just published in Journal of Preventive Medicine. It's a January issue. Just when it was about ready to break, we were all in a meeting in Virginia, and Louise Floyd, who's our project officer at the CDC, called and said, the CDC has just pulled your press release because you didn't tell the women that they had to be abstinent from sex. We gave them choices about contraception. But anyway, I won't get on that soapbox, but that's... Nonetheless, after 9 years of very intense, we still published the paper and it's out, but press release didn't happen. Anyway, so Project Choices was a study where we were interested in using what they called a preconceptional approach. Here's where it's published in case you want to have a look at it. And so we started out with just an epidemiology survey. These settings that we have identified as having women at risk, are they really settings where the women are at risk? So we wanted to characterize the population and look at their level of risk, identify variables that were correlated with risk, and look at predictors. I'm going to go through this fairly quickly because I've got this on one of the little study I want to tell you about. But basically then, so everything that we had a whole range of sites from our jail and treatment centers where the women were, really using a lot of alcohol, inner city primary care in Virginia, OB-GYN clinics, all the way back through this other end of the spectrum with Mark and Linda's media recruited sample. And this was just putting an ad in the brow. You know what happens when you put ads in papers. Weird people sign up. So it was this whole range of people at risk. Women had to be fertile, so they couldn't have had their tubes tied or anything like that. Had to be having unprotected sex. 7 or more drinks in a week, or 5 or more drinks in one day, and they had to have done this more than once in the last 6 months. That was just our admission criteria. So we screened almost 3,000 people. You can just kind of look at the demographics here. Pretty low income group. 70% of them made less than $20,000 annual household income. Half of them were unemployed. So this was just in these settings. In general, 32% of them were infertile. But if you look down here toward the bottom, 12% of them were not using contraception, and 12% were not using correctly. Okay, so whatever their method of contraception, we looked at the American College of Gynecologists, OB-GYN docs, and their recommended methods, and that's how we judged whether people were using them contraceptively correctly, and 8% were not using them at all. 71% of them drank, 31% were binge drinkers, and 25% were frequent drinkers. Okay, so we identified these seem to be the women. National estimates for the general population for alcohol-exposed pregnancies are about a 1 to 2% risk, and our people were about 7 times more likely to be at risk, and I'll show you that by setting. All the sites were at increased risk. Okay, so here it is by setting. The community. Oh, what happened? There it is. Okay, so these are our various settings. You can see our risk levels all the way up to 24% in the recovery, the treatment centers, 21% in the jail. So we identified women who were at pretty high risk. So once we got through with the epidemiology survey, we moved on to a feasibility study. And the feasibility study was a one-arm trial where we looked at reducing the risk in these various settings. This is published in Pediatrics in 2003. Okay, so we didn't have a control group for this part. We'll get there. We had one down the road. So, but this was just to look at the promise and feasibility. Could we actually pull this off in community settings? Okay, so this wasn't research that was going to happen in the lab. This was going to happen in the places where you all work, you know, in these actual settings. So we wanted to get the women to reduce their drinking and use effective contraception. Now, these were not pregnant women. Okay, these were women at risk. So if they were pregnant or ended up pregnant, and some of them did, you know, our recommendations, of course, were no drinking during pregnancy. We wanted to know if we could develop and implement an intervention to target both the drinking and the contraception, because many interventions will target one behavior, but what about 2 behaviors? And what about giving the women a choice? You know, if the woman, you know, yes, we wanted her to reduce her drinking clearly, but if she wasn't ready to do that, would she adopt effective contraception? Okay, so there were kind of 2 pathways to this what we called reducing their risk, and could we do it in community settings? Okay, so again, being not at risk was having less than 7 drinks in a week, so less than 1 a day, and no days where they had 4 or more, or 5 or more drinks, and using effective contraception. So we screened 2,400 women, consented and enrolled 190 of them, and we did motivational interviewing, and our manual was based on the Transtheoretical Model, so looking at the processes of change. How can we let the counselor work with the woman around her behavior, figure out where she was maybe lacking in her change process use, depending on her decision about change, and use motivational interviewing to move her forward. Okay? None of these women, like in our setting in the jail, Harris County Jail, these women didn't present for treatment, right? So they didn't come to us saying, I want to change my drinking. These were women in jail, and clearly we had very good, we had a lot of interest. People want to see a counselor when they're in jail. They've got nothing else to do. And so they were very receptive to us. So, for example, in our setting, we trained people in motivational interviewing. These were all people with mental health, so a social worker or doctoral psychology students, or we had a couple of clinical psychologists. So they were all trained mental health professionals. Went into the setting and worked with the women, had two sessions using motivational interviewing before the woman was released. And I'll tell you I'll tell you a little bit about that intervention. When the woman got out of jail, we arranged for her to go to a family planning visit. So in our case, it was Planned Parenthood, and they could get free contraception services if that's what they wanted. Then they came back to 2 more sessions, and then we followed them. In the feasibility study, we just followed them for 3 months, and then again at 6 months. Okay? So we wanted to know if a greater proportion of them would reduce the risk of having an alcohol-exposed pregnancy after participating in our intervention than those in the control group. And the control group just got brochures and referral to treatment in the community. And we wanted to look at other variables that were related. Okay, did the timeline follow back? Many of you are familiar with this. The women gave us information. It was a very intensive interview, but the women did really, really well with it. We asked about their alcohol use, their vaginal intercourse, the birth control, and what type of birth control they were using on a daily basis. And we had them keep a journal. I'll show you a copy of the journal in a minute so that when they came in, it would help kind of facilitate their reporting of their behaviors. In the first session, we reviewed a fact sheet. So we asked the women what did they know about alcohol? What did they know about alcohol and fetal alcohol spectrum disorder, the effect of alcohol on a developing, on a baby. And we asked them what they knew about contraception and the different types of contraception. We advised that they go for a family planning visit. We did not tell them they should get on contraception, but we said just go and talk. If you don't want to, can be a well woman exam. If you don't want contraception, that's perfectly fine. It's completely up to you. We asked them to keep a journal, and we presented thinking exercises, and those thinking exercises were just a decisional balance. That's what we called it that. And we left a package for them. When they got out, there was 35 cents for a phone call. So when they got out of the jail, they went down to get their property, a taxi voucher for them that we'd filled out in advance so they could go like home, to someone's house. They couldn't just use it to go anywhere. And the reason for that is because in Houston, I don't know if a lot of jails do this, but the women were released at about 5 minutes after midnight. That's when they get out of jail at Harris County. And they're released onto the streets in downtown Houston, and they're out there driving around, or, of course, the drug dealers and, the guys who were wanting them to get back in the same trouble they were in before, and try to recruit them to be sex workers and all that kind of thing. The only thing they do before they release the women is they release the men. So the men get out of jail at like midnight, right? And then the women get out. Why do you think they get out at 1 minute to 5 minutes after midnight? Any idea? Absolutely. So that they can get the money for the day. Absolutely. Yep, that's exactly why. So these women were pretty high risk, just once they got out of the jail. So we tried to facilitate them getting to a place where they were safe. Sometimes we put little makeup in the packets. It was like a little portfolio. It was a plastic thing with a zipper, and they felt like a little briefcase. We put some hard candy. Little things that, and when you're using motivational interviewing, they talk about little small things have a big impact. So we had these kits for them. And again, the different sites, we all had a similar intervention. Of course, ours, the other sites didn't have a residential component. Did decisional balance, good things, not so good things about using birth control. Starting out, what are some of the good things? And we said, here's another woman, an example, and all that sort of thing that you would do if you're doing good motivational interviewing. Second session, we gave them feedback. Very similar, those of you who would remember Project Match, they gave very personalized feedback. So this was not so different from that, these 4 sessions. Reviewed and discussed their journal, talked about their family planning visit, got them ready for the visit, reviewed again their decisional balance, and we asked them to complete self-evaluation. Those are those rulers we just did. So they did the rulers together. Then we had them do a goal statement and a change plan. We worked really carefully with this because Mark Sabell, for some of you might know Mark, he really struggled. We all struggled together, but Mark came up with some very nice ideas for, you don't want a person to have to set a goal if they're not ready to set a goal. That kind of goes against the whole notion of trying to do motivational interviewing. So I'll show you the change plan that we came up with. And then they looked at temptation and confidence profiles. So it's basic feedback. Here, you're drinking. Do you drink at moderate levels or risky levels? Well, of course, to get in the study, they were at risky. So that was already there. How much money did you spend on alcohol last year? Based on what you told us, here's what you drank, and here's what you cost. And it's only for $3.50. In a bar, you would have spent this much money. Well, a lot of our people are pretty, very low income, and they say, gosh, I could have bought a car for that amount of money. And for the women, the calories they consumed from drinking alcohol seemed to make a big difference. Here's the empty calories that you had. They were all at risk, so we talked about their pregnancy risk. Did the rulers. This ruler we did importance, confidence, and then readiness. So this is just kind of a stage of change ruler that we worked with them. And the target behavior was, of course, drinking below risky levels, and the other target behaviors, we had 2 rulers, one for alcohol, one for birth control. And here's the change plan. Your choice would be, would you plan not to drink at all? Or if you are going to drink, what would, an average day when you do drink, what would you drink? Or in an average week? Or maybe never to drink more than X amount of drinks in one day. Again, these women were not presenting for treatment, so we weren't going to come in and say, you got to be abstinent, okay? We did say if you're pregnant, you should be abstinent, but, let's make some healthy choices around drinking. Now, many of them, it turned out, were dependent, and we would always have the counselor say, my advice to you, most people find out when they're drinking at dependent levels that they can't, they have trouble reducing to risky drinking. My clear advice to you would be, that abstinence would be a goal that I would recommend for you, but it's completely up to you. And then we did their temptation and confidence profiles, and I think this is really cool. We just used the, the ASCQ, the brief situational BS. Gerard, help me out. What is that? Helen Anna's BSCQ measure, and looked at temptation and confidence. Or you can use the, Transtheoretical Model has some self-efficacy, temptation and confidence. This was collaborative studies, so we had to pick and choose instruments. And then we just plugged them into PowerPoint. Those little graphs. You just plug their scores in, and it comes out with these very cool graphs. And I love this. It's super simple, and we've been using these in all of our studies. We sort of came upon this one day. I had this big argument with Linda, who said, "You can't use that clinically. Look at that." And I said, "Oh, it works beautifully." And it does. She even came back and said, "Wow, this is great. This is a great clinical tool." So you show them, because this is the woman's score. This is her own score. So when you're giving feedback, how tempted would you be to not use birth control in this situation? And she would say, so what you told us was, we plopped them in, gave them a pretty colored chart. If you've been drinking, you're pretty tempted to use, but in this case, you're confident that you wouldn't use. Okay? We also did one for alcohol. So it was her own feedback. Anyway, session 3, we talked about the family planning visit, recapped, and session 4, again, we just went kind of back over all that. Counselors, on-site training in motivational interviewing, centralized training in the study protocol, weekly supervision, very intensely supervised, and each therapist saw pilot clients. Good quality control. So before the intervention, 100% of them were at risk, and 6 months post-intervention, 68% of them fell into our not at risk category, and still 31%, 32% were at risk. Okay? Here's our completion rates. So the women, interestingly, and this is aggregate across the different sites, but the women came back, which was pretty surprising. A lot of the jail women came back. So what happened? 18% reduced their drinking, 34% started using effective contraception, and 48% of them did both. Okay? So the women were given a choice, and many of them chose to do both. Okay. And here they are by setting. And I'm going to fast forward here just for the sake of time. But we learned that the intervention was promising. More women chose to contracept than reduce drinking, and it showed enough trial to move on to an efficacy study. So the CDC funded the efficacy study. Again, this is the one that was just published. Same thing, we screened women, and we had 830 people randomized. Here are the characteristics. Again, the women are about mean age 30. About half of them were single, low income, very similar to the feasibility study. This is their audit score, about 18. And at 9 months, 69% of them reduced their risk for AEP. 15% more women in the intervention group reduced their risk. So there was a treatment effect between. It was great. And of the intervention women, 32% used effective contraception. So the odds ratio was about 2.2 or something. So people in the intervention group were about twice as likely to reduce their risk. Okay. So now what? How do we implement evidence-based intervention? Okay, this is a good example of an intervention that seems to be effective. How do you put it in the community? Okay? We started getting calls very soon after we published this. "Oh, that's great. I'm glad you're in Texas. We want to take Project Choices and put it in our all of our community health clinics. We want to, really use this, which is great and important, but we don't really have time to do 4 sessions. Can we do Project Choices Light? And can you come and teach us how to do this, in 30 minutes? And can we use, not trained mental health professionals, but can we use a nurse, or can we use, a health worker, or can we use somebody, bachelor's degree person to come in and do it?" So, those are the practical questions. How do you do this stuff in the community? Our counselors were highly trained in motivational interviewing, and we monitored the intervention. they think then you're likely to be dealing is their thinking. Okay, so you get rid of that end of the spectrum. Okay, what better motivation could there be? So they called and said, we really like this motivational interviewing stuff. We love the stages of change. We love measuring motivation. And we would like for you, they asked Carlo and I and Kirk, could you come to Singapore and teach us how to measure motivation? Because we want to know who in our prison system is motivated, right? A lot of them are gone, right? But the rest of them in the prison system, we need to assess motivation. Well, we're just like, whoa, wait a minute. What are you going to do with that measure, right? So we got pretty concerned about that. So instead of us going there, they came to Houston, and these are representatives from their 9 different prison programs, and talked with them, did a whole week of training with them about assessment and motivational interviewing. Okay, and then very quickly, I'll just take a few minutes to tell you the study that we're just steeped in here. We decided a few years ago to those processes of change that I told you about that we like so much. If you could write a treatment and you could facilitate process use, what would that look like? So we wrote a treatment manual. We started out developing a project for a homeless program. We wrote a curriculum, and it looked like it was kind of neat. It was based on the stages of change, and every session was devoted to facilitating process use. So one session would be geared toward consciousness raising, and another toward the self-reevaluation. And we wrote it in a way that it could be used in group therapy, okay, because lots of people in the community are doing groups. So we'll do it in groups. We'll have an exercise for every session. We'll write it very clearly, but it will be based on the Transtheoretical model. People can use motivational interviewing. So we wrote this manual for the homeless program, and then Carlo said, we ought to see if anybody wants to publish this. We went to Plenum, and they said, no thanks, but no thanks. And we went to Guilford Press, and they said, we want to publish this. Don't send it to anyone else. So that was actually in 2001, and it's been kind of one of their best sellers ever since. It's done really well for them. It's not rocket science. It's based on the processes of change. But it tells counselors, how do you do this? Somebody last night was saying, where are you, Charles? Is Charles here? He met me last night and decided not to come. He uses it in his class, in his social work class, and because it's something that counselors can kind of have to take with them into sessions. And if you want, you can use it individually. But we decided to test it for working with people with cocaine and put it up against the toughest educational advice group that we could do, very rigorous ed advice group. And so here are our investigators. And NIDA funded us for a 3-year study to look at it. It's one of their, it's an R01, but it's kind of a developmental study to how do you refine this for cocaine. And here's our investigators. You can see Gerard's on our team here. Thank the Lord. And tomorrow he's going to help us find significance somewhere. So it's based on the experiential and behavioral processes. And as you can see, the processes kind of going through the stages of change. We talked a little bit already about process use. So what do we think we know? We think we know that the experiential and behavioral processes based on the literature are good predictors of outcome. They're related to stage of change, and it appears that people have to go through the experiential processes before they move on to the behavioral processes. That's what most of the research has shown so far. But is it always that straightforward? Okay. Di Clementi, I got this from your book, Gerard. It seems like there's an understandable process, but no simple linear path through that process. And so here, how do we figure out, are we putting things in the right places? How do we make all this fit together in the right way? So do clients use these processes to facilitate movement through the stages of change, or the processes markers of change, markers of their progress? Okay? Can we elicit change process use? If so, can we assess a client's change process use and target? So if you're low on experiential processes, can we target that? So can we do some measures? And what strategies are most effective for targeting specific processes? Can we identify exercises that facilitate process use? some treatments better at facilitating than others? Is motivational interviewing more effective in facilitating experiential processes and maybe CBT for the behavioral processes? And is facilitation of this best done in individual therapy? Can you do it in group? Okay, so I'm not going to go into a lot. So we have the study going on, and each one of these sessions, it's based on the manual. We had the investigative team come in. We made 12 sessions down from these 29 sessions. It's a little hard to read this slide, but every one of these sessions targets a particular process. Some of them teach the stages of change, for example, to the clients. Clients love learning about the stages. It's great. I mean, they do really well with it. And can motivational interviewing be adapted to the group setting? Okay, so we wanted to look at that as well. We published this article on MI in groups this past year. And basically, how do you adopt it to groups? How do you adapt it? We came up with this acronym. You got to have an acronym if you're doing motivational interviewing. This one is OPEN, personal choice, environment, non-confrontational. So we kind of go through the group using motivational interviewing, and we called it group ORs. Okay, we was going to play a little piece of a transcript, but the sound system for the computer here won't really allow me to do that. But basically, you can see what we're doing in group is eliciting change processes. Can you really do that? Can people do motivational interviewing? Well, it turns out, in my experience across the study, that people do it, and the members of the group do motivational interviewing with one another. We don't teach them how to do it. We tell them it's a non-confrontational group. We teach them about developing empathy, and that we're not going to confront each other here. It's going to be kind of different. And pretty soon they start doing reflections with each other. It's amazing. We transcribed these tapes and sent them off to the University of New Mexico. You can just kind of see some of the change talk language here. And we had one of Bill Miller's expert coders code it using the motivational interviewing treatment integrity code, looking at empathy, spirit, collaboration, evocation, and autonomy, and we got real good scores. Those of you who know the Mighty know that these are very good scores. The scales are go up to 7. So the therapists each got scored. So it seemed to work pretty well. Okay, so just to wrap up, future directions are, do we want to identify where the client is in the process of change? Can we teach the client about processes? The ideal treatment matching would be to have the therapist and the client consciously collaborate on the same goals and tasks that are required at each stage. I really have this in my presentation that I did at ABCT, not just sucking up to Gerard because he's here, but it just happens to come from a lot of stuff from his book. Avoiding simple views of motivation, keeping in mind that experiential and behavioral process use happen outside of the session, and how do we track a client's motivation? And use change processes and adjust our strategies. Remember that when people are using multiple substances or have different behaviors, diet, exercise, condom use, they're going to be at different places in the change process. Clients are their own agents of change, and they'll usually tell us what we need if we'll listen, okay, what they need. So we're doing screening and brief intervention. We just wrote a proposal. We're writing it due Monday. To use this in pediatric trauma settings. Now that we think we know that these screening and brief interventions work, trauma settings are mandated to use it. I have a trauma surgeon who came to me about as soon as I moved to Austin and said, I'm medical director for trauma services. We're mandated to do that. He's a pediatric surgeon, and they have to do it with kids. In the trauma setting. Well, what does that mandate mean in a pediatric trauma setting? So we're writing a grant. He's a great guy. And so we're writing this grant to say, what does that mandate mean? And can we screen parents of kids in the pediatric trauma setting and do interventions with parents because the kids, have been hurt because 50% of, their admissions are car accidents. And how many car accidents, are caused by people who are drinking. Okay, so this is where we're hoping to be. You've probably seen this before. And this is where I am right now. You've seen that too. Okay. All right. Well, thank you. Thanks for bearing with me. That was a lot of information.